So today I want to talk about a project my team and I have been working on for the past a year and a half. And particularly, we're interested to see how we can use a patient-centered approach to address the racial and ethnic disparities in the pathways to dementia diagnosis. So I know for the audience, I probably don't need to spend too much time to talk about the background of ADRD, but just want to briefly touch upon that. So about 1 in 10 older Americans are living with ADRD, and the prevalence rate is higher among older adults who are self-identify as Black or Hispanics. So the prevalence rate of Alzheimer's disease-related dementias among Black population is about 13.8%, and then the rate is around 12.2% for older adults who self-identify as Hispanic. And it is one of the most costless conditions to the society. We're not only talking about medical costs, but also long-term care costs, especially for older adults with moderate to severe stage ADRD. They often require around-the-clock care. And another thing I want to point it out, and I think I will talk more in my presentation, is the involvement of family members. So family members are very important piece of the care for older adults living with ADRD, and actually more than 80% of them are currently receiving care from one or more family members. Although there are currently no treatment to stop or reverse ADRD, although there's a very controversial drug that was approved by FDA last year, but still there a lot of interest and benefit to have an early diagnosis of this condition, such as allow older adults and their family members to acquire appropriate medical services and the social resources needed for this condition, have access to treatment to manage symptoms and opportunities to participate in clinical trials. We heard that actually shared quite a bit among our family members of dementia patients, and more time to plan for the future as a family, and especially for caregivers, actually have the being officially labeled as a dementia caregiver that actually prompt more official referral or linkage to different social services or dementia support programs. The reality is that receiving a timely diagnosis of ADRD has been challenging, and older adults, especially older adults from racial and ethnic minority background, often have delays in their ADRD diagnosis. A paper published in JAMA Neurology last year, they used Medicare claims data in California. What they found was that for older adults, specifically older adults who self-identify as Black, Hispanic, or Asians, they are not only less likely to receive timely diagnosis of ADRD, they're also less likely to receive comprehensive evaluation of AD compared with their White counterparts. So part of the reason is that why there are potential delays in ADRD diagnosis, especially among older adults from racial and ethnic minority background, might be the complexity of ADRD diagnosis. So the current guidelines recommend a tiered diagnostic approach. Start from a wellness visit.
Want me to give it back to you?
Start from a wellness visit, then follow up with a problem-focused visit for persons with concerns, which is often referred as a brain health visit, and followed by a more comprehensive visit for patients who have neurodegenerative conditions suspected. The third part can be done by primary care provider, or the primary care provider can refer the patient to be seen by a specialist. So overall, the point I was trying to make here is that the diagnosis of ADRD often will occurred over an extended period and often involve multiple providers, procedures, and across healthcare settings. So I was trained as a geriatric, trained more like a social gerontologist. And one of the theories that we use in social gerontology is a life course theory. And a life course theory in this setting actually provide a pretty valuable framework for us to understand the care processes leading to an ADRD diagnosis. So drawing from the theory, the care processes, or we call that the pathway to ADRD diagnosis, can be conceptualized by several key components. including timing, which can be operationalized at the diagnosis date, and duration can be operationalized at the time interval between such as initial cognitive assessment to a specialist visit, and sequencing can be operationalized as the sequence of care, such as from primary care setting to a specialty care setting, then to the diagnosis. So the figure on the right side showed several examples of potential pathways to ADRD diagnosis. So an optimal pathway A, may begin with the recognition of symptoms, followed by a primary care visit, a subsequent specialist visit, and then a clinical diagnosis from a specialist. And alternatively, a few qualitative studies, including our own, that found that racial and ethnic minority older adults are more likely to follow a crisis event pathway, that their ADRD diagnosis often occurred at a time of medical crisis or hospitalization, as seen here in pathways B and C. So to be able to effectively address the disparities in ADRD diagnosis, or to ultimately promote the early identification of ADRD, I think to identify the care processes that patients follow prior receiving their diagnosis might be the very essential very first step. And to map out these care processes can help us to identify critical time points or highlight the missed opportunities in our current clinical practice to reduce the racial ethnic disparities in dementia care and promote early diagnosis of AD. So for our team, we're interested to see how we can map out these care processes using the EHR data. And we're trying to also assess whether the care processes differ across older adults from different racial and ethnic groups. So I want to talk about, so basically we have data from the Duke House, the EHR data from the Duke Healthcare System. So the first step, we're trying to identify the patient population of our interest. In this specific case, we'll identify every single patient being seen by Duke with the discharge or final diagnosis code that will also list as the primary diagnosis of ADRD. And we'll use the list of ICD-9 and 10 codes based on the CMS clinical, the chronic disease warehouse algorithm to be able to identify these cases. And for those who have been at Duke long enough, you may know that about a decade ago, around like 2014, Duke switched the electronic healthcare record system from legacy to Epic, and to be able to make sure the consistency of documentation with limit patient with the very first ADRD diagnosis occurred after January the 1st, 2014. And we know that we're in the RTP area, also share practices with UNC, WICMEDS, etc. So be able to really capture all potential patients' interaction with our healthcare system with further limited patients to those who have a Duke PCP on file. And this is actually a retrospective longitudinal design, but it's a bit different from other longitudinal studies. So I want to talk a little bit about how we structure the data, and that might be helpful when I start talking about how we map out the care processes. So think about this as a timeline, and we actually start from the endpoint first. In our case, this is the encounter when the diagnosis of ADRD occurred. Then we try to trace back to the potential earliest encounter that we can find in the healthcare system. So that basically gave us a time frame in terms of the starting point and endpoint for each individual patient. And then we're trying to fill in the blanks along the way. Those are, So those are encounters that happened between the earliest encounter and the ADRD diagnosis encounter. But those visits, the circles represent all types of encounter. It doesn't necessarily mean those are the encounters related to their memory concerns or cognitive impairment. It could be visit to their primary care provider about hypertension or diabetes management. And for the diagnosis encounter, we're also interested to see whether we can tell the stage of ADRD and the patient was diagnosed at that point. So to be able to do that actually was not very straightforward because those we cannot tell that based on ICD-9 or 10 codes. So had to use some of the scoring from the cognitive test or just use the natural language processing to help us to identify specific terms that relate to the staging of ADRD. So we're actually doing that doing that piece right now. And here I want to show you a little bit about just some descriptive stats of our patient population that we included in analysis. I know it's a pretty busy table, so I want to draw your attention to the two red boxes here. So one thing first I want to draw attention is to the encounter type. This is where the diagnosis happened for patient, especially we're trying to compare where the location of diagnosis between non-Hispanic Black patients and non-Hispanic non-Hispanic white patients. As I noticed that also this was consistent with prior research that we found for Black patients that were less likely to receive the diagnosis from AD specialty. For AD specialty, we're considering neurology, neuropsychiatry, geriatric psychiatry, geriatrics, etc. But they're more likely to receive the diagnosis from a primary care provider, or the diagnosis actually occurred during a hospital stay or ED, which is similar to prior research. This finding is very similar to prior research. Another thing that I want to draw attention to is at the bottom of the figure that we often think, okay, older adults who come from racial and ethnic minority background, they're having access to care issue. But what we're seeing here is that for Black patients actually had twice as many clinical encounters with our healthcare system prior to their ADRD diagnosis than their white counterpart. And at first we thought whether age played a critical role here in terms of age at diagnosis, but actually we didn't see much of a difference regarding the age of diagnosis between non-Hispanic white and the non-Hispanic Black patients. So this is some early signals suggesting there are potential differences in the care processes regarding the ADRD diagnosis. So we're trying to see if we can map out all the care processes the way I illustrated in figure 1 a few slides ago. To able to do so, we're applying a data-driven clustering method called a state sequence analysis. This is a method derived from the social sciences and was originally applied to study the ordering of life course stages. But in the recent few years, it has drawn a lot of attention in the medical research as a way to potentially identify specific patterns related to care processes, or to look at how early life stages relate to a specific health outcome. But in our case, we're really interesting to see whether we can use this type of method to help us identify the care processes the patient follow prior to their AD diagnosis. So I want to talk a little bit about the key concept in the state sequence analysis. The state in this specific context refer to where the patient is on a given day. So think about if we have a patient status on daily basis, the patient can on given day could stay at home, maybe had a primary care visit or visit the emergency department or hospitalized, etc. So we actually listed the possibility here. We also color coded that, and a sequence is the ordering of all these kind of states. So think about a week. So the patient could have like 3 days. The first 3 days, the patient was just stayed at home, and on day 4, the patient had a full accident and was admitted through the ED. And through the ED, the patient was further hospitalized because of hip fracture. So this is a kind of a sequence of all the state in a given week of a week that patient potentially can follow. So at first we want to see, okay, whether we can map out the patient status on given day and to cluster into group patients who share similar patterns as a group. But quickly we learned that actually there's more data. There's a lot of state than we expected. So to be able to really speed up the computation time, so we're trying to do some consolidation at this point. The one thing we wanted to see is whether we can consolidate daily data into weekly data. Then we're facing another issue is because of all the possible combination a patient can have on a weekly basis. I just list a few things here. So a patient can have multiple AD encounters, or can be seen by a primary care first and then got referred to be seen by another specialist, etc. So we're facing another issue in this specific case, rather than to kind of reducing the number of data points will open up more possibility the patient's state that can have on a given week. So we look into the literature, and there was a group of researchers in Canada applied a state sequence analysis to map out their care process among patients with COPD after hospitalization. One of the strategies they use is they came up with a priority list. So for some type of encounter will receive a higher priority over others in a way to reduce the all the possibility in a given week. So after talking with my clinician colleagues, my mentors and collaborators, we come up with this priority list. So overall, for any given week, if the patient had a visit to a neurologist or neuropsychiatrist, basically AD specialty visit, that week will be labeled as AD specialty, and then the second priority will be hospitalization, followed by primary care and ED, then other specialty and home. And we also went back and forth regarding the priority for primary care versus ED, and in our sensitivity analysis, we actually flip these two orders, but the patterns largely remained. And here is like a bird eye view of all the care processes that the patient will include in this analysis. As you can see a lot of coloring going on here. So that really prompts us to look into, okay, if we can identify some typologies among the patient, whether we can group them based on the care process they followed. This is actually 2 years of data by week prior to their ADRD diagnosis. So we eventually actually identified 20 typologies here, but for the illustration purpose, I won't get into all the 20 typologies that we found, but I want to show you some examples that might be generate some interest for further discussion. So the first one, if you recall, the green color represent other specialty care. As you can see, this is a group of patients who have been interacting with the healthcare system a lot over the 2-year period prior to their ADRD diagnosis, might reflecting a group of patients who had a lot of other multiple comorbidities even before their ADRD diagnosis. And the second one, as you can see, I don't know whether you can see my cursor here, but there are 4 dark blue panels that are placed pretty much even space between each other. And the blue color represents primary care visit. So this might reflect a group of patients who had a periodic primary care visit prior to their ADRD diagnosis. And the third one here, you probably notice a lot of white color pretty much across this panel, and not until the tail end you can see a dark blue bar there. This represents a group of individuals who didn't interact with the healthcare system a lot until right before their ADRD diagnosis. So overall, the takeaways, there are considerable differences in the healthcare utilization patterns, and older adults from different racial and ethnic groups may follow different pathways. So this is still work in progress, and so I won't call this conclusion, but the lessons we learned so far is there considerable variation in the longitudinal pathways to ADRD diagnosis, and because this will also demonstrate, this is kind of an innovative part of this is to apply a clustering method derived from the social sciences in clinical research. So we actually demonstrate the feasibility of using the state sequence analysis in healthcare service research. And there's some preliminary evidence suggests the potential racial differences in the diagnosis pathway of ADRD. And we're in the process of examining the racial and ethnic differences in identified typologies of pathways to ADRD diagnosis. And also, we're trying to identify to the extent to which the pathway typologies associated with a timely diagnosis of the ADRD. So we're actually trying to link the typology with the state of ADRD to see if there's any association there. And because the heterogeneity we found based on EHR data really prompt us to do qualitative interviews to really understand from the patient perspective what the key barriers and facilitators that encountered as they went through this diagnosis process. So, and for the qualitative interview, we actually wrapped up the recruitment 2 months ago, and it was kind of an interesting process because we're trying. When we wrote the grant, that was about 2 or 3 years ago. That was before the pandemic, when we're trying to interview care partners of individuals who recently diagnosed with ADRD. We thought, okay, we can do community-based recruitment, but because of COVID, we kind of had to pivot our approach a little bit. So we end up trying to identify care partners through the electronic health record. So our ultimate goal is to see, okay, if there's any way we can have an automated approach to be able to identify all these caregivers based on the EHR data of the patient. But as we're trying to establish this process, we run into several different issues. I think that might be interest to someone who is interested to use the EHR data to design embedded pragmatic trial for dementia caregivers. So in the EHR data, although some of the physicians notes might know the living arrangement for the patient, but those information are not readily available. And we think about care partners, and in the EHR, there's no field, there's no label for care partner, and you probably will be able to find the information of the patient emergency contact, but are the emergency contact personnel are the same as care partners? At first, we really don't know. And similar thing, are we talking about the patient's DPOA or DPOAF? That is another concept or another flag we were able to find in the EHR, but that suggests that is exactly the patient primary care provider the patient primary care partner. That is a question mark that we had as we're trying to establish that. And another ethical issue is because we're trying to interview care partners for them to tell us the care process their loved one went through. So basically the content we're going to talk about is more focused on the patient rather than the caregiver. So we run into the issue in terms of whether we need to actually also obtain the informed consent from the patient. And so those are the things we run into. We're able to pretty much solve all of that through these processes and the strategies that we use. And also the strategy we used in this study also have been validated from other studies that works pretty well. So we actually first identify all these patients and their contact information from the EHR. We send an introductory letter or email to the address or email address on file. Then we follow up with a phone call trying to identify if the person who received the email or the mail is the right care partner and whether they are aware of the diagnosis processes that the patient followed. So why we're interested in that, because we know that the EHR data only tell part of the story, that from the healthcare system perspective, we also want to do a little bit kind of a small validation to see how complete the care process we're able to identify from the EHR, from the patient and the caregiver's perspective. So we did a quality interview embedded with the cart sorting activities, basically as a care partner to help us to put things in order, what happened first, what happened next. And here is one of the examples the care partners provided us regarding the diagnosis processes for one of our study participants. And we're able to identify, based on the interviews, a few barriers and facilitators regarding the diagnosis process that the care partner and their loved one went through. So the one thing that is being highlighted in multiple interviews, actually almost all the interviews, is related to the limited knowledge about ADRD. They talk about the limited knowledge not only limit to the care partners we interview, but also their family members. And they've shared that they have limited knowledge not only related to the ADRD, the disease itself, but more importantly, what to do with it. And we actually distribute a survey among these care partners, and less 30% of Black care partners report have adequate knowledge, self-reported have adequate knowledge about ADRD, where the proportion is around 60% among their white counterparts, which highlights some differences regarding the knowledge about ADRD between Black and white participants. And another barrier the care partners share is access to care. More specifically, they mentioned about often require a long way to get a referral, and some of them mentioned that it took them more than six months to be able to see by a neurologist. And they also mentioned that because it's a long process, they often need to come to the clinical hospital multiple times, also be able to have a time that works for everybody involved in the care to all come together along with the patient can be quite frustrating regarding the scheduling. And another interesting thing the care partner mentioned about barrier related to ADRD diagnosis is the denial. Multiple care partners share that they notice some changes in the patient, but when they bring it up during a conversation with the patient, if the patient had a denial regarding, no, I'm just fine, it wasn't nothing special, or the denial from other family members that potentially can cause delay in help seeking. But there are also facilitators the care partners share with us along the process. One facilitator is the really kind of relate to the barrier is a timely response and a support from the care team. And they really stress the point that when they talk about the care team, they're not only referring to the physicians, but also everybody else they interact with them in the clinic, such as nurses, social worker, and a pharmacist. And another facilitator they mentioned is the importance for the care team to be attentive to their needs, not only the patient needs, but also the family needs. So this is one of the quote that one of the caregivers shared with us. So they had a visit with a neurologist, and they really liked that physician, because as soon as the physician said, yes, now I have two patients, I have the patient self, and I also have your family, that was like a meaningful thing for the physician to say to the family that may to actually really showing the physicians being attentive to the family needs. And other facilitators, since we did a study during the pandemic, they mentioned that some information they found from the internet can actually was very helpful because it linked them to different local support programs. Strong family ties was another facilitator. They mentioned that although sometimes family members can be a potential barrier, but if all the family members were on the same page to be able to go through this together, that was perceived as a facilitator, and often the family member, the caregiver share that the strong family tie was one of the motivation to really push them to find some answers along with their loved ones. And faith was another thing that was predominantly mentioned among the interviews that we conducted among Black caregivers. We asked them what helped with along the process. They share with us. They pray a lot. They go to the church, and that actually give them the strength to be able to navigate through this very devastating process. The last facilitator they mentioned is the validation from another person, whether it was another family member or the patient's primary care provider, a provider that was often very helpful for them to move forward to seek additional help, to get additional evaluation for the patient. So besides the facilitator and barriers, I think we're really interested to see what we can do, especially from the healthcare system, to improve the process. So here I put a few exemplar quotes here from the care partners, but I think the key takeaway is that those care partners, as they were involved in the care process, even officially become the dementia care partner. So they are being already very heavily involved in the process, but they receive a less of a limited support through this process. They also perceive that finding some answers was very devastating, and they love somebody who can be there with them to help them connect dots, to be an advocate for the patient as well as for them. So all of that really prompt us to think about how we can develop intervention to really help the care partner and the patient as they navigate, as they trying to find some answers as they navigate through the healthcare system. So one thing is because they mentioned about the barrier regarding limited knowledge related to ADRD, so we actually did a systematic review to find intervention to promote dementia knowledge, especially among racial and ethnic minority communities. What we found is that for these interventions are quite effective regarding promoting knowledge about dementia, and also to bring some positive attitudes regarding dementia, also combat some stigma around dementia in some communities. But we found very limited data on whether this increase in knowledge will lead to more brain health utilization or help seeking behavior. That's a big question mark. I think we still don't quite know yet. But overall, I think all this evidence based on the EHR data, the quality of interview, and systematic review we did, we're really trying to see if we can design a patient navigator intervention to promote early identification of ADRD, and also to address the racial and ethnic disparities in dementia care delivery. So this is a model that was developed by a group of researchers in Australia to really illustrate how potentially a navigator can be embedded in the healthcare system. But in our case, we're trying to think, okay, what the roles the navigator may include, but we're thinking about potentially the navigator can provide educational information to the older adult and their family members about cognitive aging and dementia, and also provide information about the diagnosis processes, such as what type of doctors they will be seeing along the way and expectation of each visit. One of the care partner was sharing with us earlier, they were saying, yeah, they were not expecting that they need to sit down with a geriatrician to talk about that for good 2 hours. But they actually had something later on, so they couldn't be there all the time, which was a little bit frustrating for them. And also we think the navigator can potentially link older adult and their family members to different support programs and resources if needed. So we're still trying at the very early phase of developing this intervention. And since we're really trying to reduce the disparity of ADRD, so we're actually keep thinking, okay, whether the intervention should be designed for everybody, or we should just develop the intervention specifically for racial and ethnic minority families to be able to help them as they need more help as along the process of receiving diagnosis of ADRD. Let me see. Yeah, I think that's all I have. But at the end, want to acknowledge the wonderful team that I have for this line of work. It definitely take the whole village to conduct this this research project, and want to acknowledge my wonderful collaborators and mentors at Duke and beyond, and the wonderful research staff I have and the students to help with the recruitment data collection, and the support I receive from Rich Equity and a few other pilot award that I got from the Office of Provost and School of Medicine. So with that, thank you, and I think I'll be ready to take any questions or comments.
Andre, I wonder if you can talk, because we have a couple of our scholars who are trying to work with EHR data on some of the unique ways you have to pragmatically work with such a complex data set.
Sure. So I think for the EHR data, it's actually quite messy. That is the very first thing that we realized. And one thing I think, especially for dementia, for people to then be able to identify patients with dementia in the EHR, there's a lot of discussion whether just based on the diagnosis code, one ICD-9 or 10 codes will be sufficient. If we really want to make sure that is the case, I think some of the literature suggesting you need to have at least the two encounters both have the primary diagnosis and final diagnosis of ADRD to be sure this is a patient with Alzheimer's disease and related dementias. So I think there's still no right or wrong way of doing that. And another thing that I think I was alluded to a little bit early on in my presentation, that this is a group of patients had pretty much a lot of interaction with the healthcare system very early on, that you will found probably more information than you expected. So it's kind of you need to be very sure about what is the most important things you're looking for. Otherwise, it'll be easy to get lost in the weeds to not be able to see the big picture. But if anybody have more specific questions regarding identifying patients with ADRD in the EHR, will relate to using EHR to map out care processes, I'm happy to talk further about that.